Welcome, everyone, to meeting number 16 of the House of Commons Standing Committee on Health. The committee is meeting today to study the emergency situation facing Canadians in light of the second wave of the COVID-19 pandemic. Today's meeting is taking place in a hybrid format, pursuant to the House Order of January 25th, 2021, and therefore members are attending in person in the room and remotely using the Zoom application. The proceedings will be made available via the House of Commons website. Just so you are aware, the webcast will always show the person speaking rather than the entirety of the committee. Today's meeting is also taking place in a new webinar format. Webinars are for public committee meetings and are available only to members, their staff, and witnesses. Members may have remarked that the entry to the meeting was much quicker and that they immediately entered as an active participant. All functionalities for active participants remain the same. Staff will be non-active participants only and can therefore only view the meeting in gallery view. I would like to take this opportunity to remind all participants to this meeting that screenshots or taking photos of your screen is not permitted. Given the ongoing pandemic situation and in light of the recommendations from health authorities, to remain healthy and safe, all those attending the meeting in person are to maintain 2-meter physical distancing, must wear a non-medical mask when circulating in the room, and it is highly recommended that the mask be worn at all times, including when seated. And they must maintain proper hand hygiene by using the provided hand sanitizer at the room entrance. As a chair, I will be enforcing these measures for the duration of the meeting, and I thank members in advance for their cooperation. For those participating virtually, I would like to outline a few rules to follow as well. Members and witnesses may speak in the official language of their choice. Interpretation services are available for this meeting. You have the choice at the bottom of your screen of either Floor, English, or French. And with the latest Zoom version, you may now speak in the language of your choice without the need to select the corresponding language channel. You will also notice that the platform's raise hand feature is now in a more easily accessed location on the main toolbar, should you wish to speak or alert the chair. And I will note that that main toolbar is on the bottom of the participants pane. For members participating in person, proceed as you usually would when the whole committee is meeting in person in a committee room. And before speaking, please wait until I recognize you by name. If you are on the video conference, please click on the microphone icon to unmute yourself. Those in the room, your microphone will be controlled as normal by the proceedings and verification officer. A reminder that all comments by members and witnesses should be addressed through the chair. When you are not speaking, your mic should be on mute. With regard to a speaking list, the committee clerk and I will do the best we can to maintain consolidated order of speaking for all members, whether they are participating virtually or in person. So I'd like now to welcome our witnesses. We have, as an individual, we have Professor Amir Ataran, Faculty of Law and School of Epidemiology and Public Health at the University of Ottawa. We have Dr. Isaac Bogach, physician and scientist, Toronto General Hospital and University of Toronto. We have Professor Marc-André Gagnon, Associate Professor, School of Public Policy and Administration, Carleton University. And we have the Honorable Paul Merriman, Minister of Health, Government of Saskatchewan. I will now invite the witnesses to make a 6-minute statement. And I will start with Dr. Ataran. Dr. Ataran, please, 6 minutes.
Good morning, Chair. Do you hear me?
Yes, thank you. I forgot to mention, I have some yellow cards. I will hold them up when you've got about a minute left, and this when your time is up. So just if you could try to keep in mind, keep an eye on that, that'd be great. Thank you. Go ahead, Dr. Ataran.
Good morning, Chair. I'm Amir Ataran. I'm a professor of law and public health at the University of Ottawa. I want to give you some of my background so you know why I'm speaking on the things I am. I'm a scientist by training. My PhD is in cell biology and immunology from Oxford University. I'm a lawyer from UBC. I taught public health at Yale. I taught government at Harvard. So I'm a bit of a generalist. Um, and in my work, I've advised organizations such as the World Health Organization, the World Bank, the UN Development Program, Médecins Sans Frontières, various pharmaceutical industries on health. I, in fact, worked in the pharma industry at Novartis, most interestingly, on a project where we had to scale up a drug by 6,000% in 1 year and solve the manufacturing and distribution problem. Now, that reminds me of where we're at, because we now have a problem of too few vaccinations in the country. Per capita, Canada is lagging behind most of our peers. Fewer vaccinations than the US, the UK, or the European Union. This is occurring for reasons I warned about in Maclean's last August, and I'm very unhappy to see much of that prove correct. I'm going to point to three areas where I think all parties agree things are unacceptable. And my goal is to try and tell you how you work together on those three issues. The first is transparency, which is really just pathetically lacking. The current government, I think, has done a terrible job on the transparency of its efforts. The work of the vaccine task force, for instance, none of the meeting minutes are public. It appears not to have met since last October. None of the conflict of interest declarations signed by the members are public. We don't really know what's going on in that committee, and it doesn't inspire confidence. You can't have the most important science decisions in generations being made secretly, and that has to end. And if it doesn't, my fear is that it will contribute to a bad-tempered political environment where you fight with each other so much you don't solve the substantive problems, and that wouldn't be desirable for Canadians. Point two, the biggest substantive problem is manufacturing. Canada needs to build resilience to supply interruptions for vaccines. We've seen what happens when our supplies are cut by Pfizer or Moderna. We've seen what happens with the European Union potentially shutting off exports when Canada is 100% dependent on European exports of vaccines right now. Countries like Australia, India, Japan, and Brazil are manufacturing. The way they do it is they voluntarily license and contract the production of the vaccines. This is, by the way, how the manufacturers themselves work. You know, Moderna, Novavax, AstraZeneca, they're producing that product not in their own facilities for the most part, but contracting out production to other companies you've never heard of, like Lonza, Fujifilm, and Emergent. And so I think an important question for Parliament to grapple with is why not pay those same contractors of the vaccine firms to lay on another batch for Canada, particularly in North American facilities where the supply interruptions would not be the same as with the European Union.
Excuse me, Dr. Adharan, you need to speak a little louder and perhaps a little slower for the translators. Thank you.
So there aren't long-term capital investments needed to solve this. What there needs to be are contracts made with suppliers like Lonza, Fujifilm, and Emergent that have the equipment and technology, and indeed are making vaccines for the companies you've heard of, like Moderna and AstraZeneca. Let's just amp that up. And the third point is, where is Canada's mass vaccination campaign? It's so scattershot right now. There's no plans for a national vaccination campaign once we have sufficient vaccines. And that, to me, is just a tragic failure. To put it in context, in 2014, Bangladesh, one of the poorest countries in the world, vaccinated 52 million kids in just 3 weeks. That's more than the population of Canada. In 1947, old technology, New York City vaccinated 5 million people for smallpox in 2 weeks. These large vaccination campaigns are able to be done even in the world's poorest places. They happen regularly. And that model of organization is one that should be considered for Canada, such that perhaps in the summer or in the fall, if there is an abundance of vaccines, it could be delivered campaign style to millions of people within a week. Any one of these three topics I've discussed, the transparency, the manufacturing, the campaigns, I could talk about it for an hour. I won't. I'll stop here and I'll invite your questions on those three or anything else within my expertise you need to know.
Thank you, Doctor. I forgot my cards, but you're well under your time. Thank you. We go now to Dr. Isaac
Monsieur le
Bogash.
Président, s'il vous plaît, un instant.
Just a moment, Mr. Speaker. I will not be able to continue at this meeting if the interpreters are unable to do the interpretation. According to the fact that some people have open mics, and because witnesses have not had sufficient sound tests so that they can be heard correctly by the interpreters. So I just want to let you know that right now there is a problem, because during all of the testimony, it was very important, Mr. Attaran's testimony, when the interpreters stopped speaking, I would hear Mr. Attaran very clearly, but the interpreter wasn't hearing sufficiently from Mr. Attaran. And she mentioned that during the intervention, and I don't understand why you're not organized so that the clerk can get this message quickly so that you can do something about it, because it becomes for me, even if I did want to hear in English, I can't hear because I am only hearing the interpreter who is telling me that she's unable to do the translation. So I think that as a linguistic minority in Canada and on the continent, we have the right to hear what the witnesses are coming to tell us. Please.
Thank you, Mr.
Merci, Monsieur Thériault. Bien sûr, si vous n'obtenez pas les services d'interprétation,
Order. We will try to deal with that as proactively as we can. I did get a note from the clerk during Dr. Attaran's testimony that his was too fast and too quiet. So I did ask him to increase. Hopefully we will go forward, and the next speaker, Dr. Bogash, I will certainly encourage you to speak very carefully and certainly loud enough. All of the witnesses have gone through the sound check. Dr. Bogash, do you have a headset?
I've done the sound check, and I've been told that it's A quality. It was too short time to get the headset, but I have a special microphone that they said was of high quality.
Okay, thanks. We'll give that a shot. So I am Mr. Thériault. I'm certainly alert to your problem, and I will do the best I can to ensure that translation happens. But please do not hesitate to raise a point of order if you're not getting it. Okay. Thank you. So we will go now to Dr. Bogash. Please go ahead. 6 minutes.
Thank you so much. Good morning, everyone. My name is Isaac Bogash, and I'm an infectious diseases physician and scientist based out of the Toronto General Hospital and the University of Toronto. Thank you for inviting me to speak at this committee meeting regarding the COVID-19 second wave in Canada. The focus of my few minutes is to discuss an exit strategy from this wave and from the pandemic in general, with an emphasis on vaccination, but also touching on other issues, including non-pharmaceutical interventions. The ultimate goal here is to halt our second wave and to prevent further waves of COVID-19. Now, most regions of Canada have emerged from peak cases in December or early January and are seeing a steady decline or a plateau in cases due to our current control initiatives. While this is laudable, we still have a long, long way to go. Vaccines are trickling in, but we won't really be able to start massive expansion of these programs until the spring. So programs are appropriately focusing on those at risk or greatest risk of severe outcomes. I want to touch on three big topics: what's working in our favor, what is working against us, and how do we navigate the winter and the spring and beyond. So let's start with what's working in our favor. Number one, we have vaccines. Of course, the current short-term slowdown is preventing expansion of these programs, but we still have some, and we're making good use of what we've got. Just to state the obvious, the sooner we ramp up these programs, the better. All vaccines approved by Health Canada and those under consideration have excellent efficacy against the virus, including the variant discovered in the UK, while there is lower efficacy on other variants of concern, for example, the one discovered in South Africa. However, the vaccines still appear to reduce infection, prevent severe illness, prevent hospitalization, and prevent death. All very important metrics. The second thing working in our favor is weather. Believe it or not, weather in Canada is actually working in our favor. As we leave winter, as we enter the spring and summer, warmer weather means less contact in indoor settings where the vast majority of virus is transmitted. These fewer high-risk contacts add up at a population level and are going to help. The third thing is that our current public health measures are working in much of Canada, and in general, Canadians are adhering to them. So what's working against us? Number one, the variants of concern. For example, the variant discovered in the UK, that's the B117 variant, is more transmissible and has a strong foothold in Canada. We have to respect this, we have to take it seriously, and we need to drill down on our current control efforts until vaccine rollout is more widespread. The second thing working against us is anything that jeopardizes vaccine delivery. This is way above my pay grade, and I'm going to leave it to you to sort that out. The third thing is vaccine hesitancy. This is pronounced in some communities, but it's still important and we have to address it. Number four is targeting missing in Canada and beyond. Number five is COVID fatigue. It's real, it's permeating all aspects of Canada, and we can't let our guard down, especially as we see a finish line on the horizon. So lastly, how do we stick handle our way through the winter and into the spring and beyond? First, we need to be very, very careful and have a careful and measured reopening strategy, especially while vaccines are slowly being rolled out. The variant discovered in the UK will make this more challenging, but it can be done. It's foolish to lift public health measures if the drivers of community infection are not addressed. Vaccine rollout will not be widespread until the spring. There's no point having more lockdowns. Lifting measures has to be done at the right time, slowly and carefully. Related to the point above is creating safer indoor environments, and that includes schools and workplaces for essential workers and those returning to work. That means integrating rapid diagnostic tests or rapid screening tests, improving ventilation in these settings, smaller class sizes, wraparound services to ensure equitable access to safety and protection, etc. The third thing is vaccine distribution. Now let's separate politics from science for a second. It may be an unpopular political opinion, but it makes medical, scientific, and public health sense to divert vaccines from low-burden areas of the country that are able to control the virus to more heavily impacted areas while there is still a shortage. Number four is vaccine supply in the short term. Health Canada has to conduct their evaluation independently, but the faster we vaccinate, the faster we're out of this mess. Johnson & Johnson, Novavax, AstraZeneca are three products with excellent phase 3 clinical trial data. We have contracts with them, and they are sorely needed. And lastly is a long-term strategy. It's crucial to support Canadian scientists and Canadian industry in homegrown vaccine production. This is a major weakness and a major health security issue. We have the talent and capability here, and it's long past time to enhance and expand these programs. It's hard to sum up all that's required to strategically navigate the second wave in 5 minutes, but I hope we can continue this conversation, and I thank you for your time.
Thank you, Dr. Bogach. We go now to Monsieur Gagnon, Associate Professor. Go ahead, Professor. 6 minutes.
Merci beaucoup.
Thank you very much. Hello, everyone. I will be speaking to you about the type of research and developmental as well as manufacturing production for vaccination for COVID-19. I'm a professor from the School of Administration and Public Policy from the University of Carleton. I have more than 150 publications, scientific articles, chapters in books, research and technical reports, as well as professional publication. I've also been an expert witness for Justice Canada and for the Superior Court of Quebec in 2020 on regulation with respect to patented medicine, and I don't have any conflict of interest. At the beginning of COVID-19, it was impressive to see how researchers across the world collaborated with open science principles to share systematically the data for the sequencing of the virus, whereas they worked together with respect to production of material for protection as well as detection. In March 2020, Canada passed legislation allowing it 6 months to go ahead with mandatory licenses for all technology that was linked to COVID-19 to be able to counter any possible shortages. This provision was not renewed in September 2020, but the federal government can renew it at any time. In May 2020, the World Health Organization set up the Technology access pool based on open science principle to encourage exchange of expertise and as well anything technology to combat COVID-19. The medicines patent pool financed by Unitate also extended their mandate to allow a sharing of patents for COVID. Initially, we thought that we would see a scientific effort that will allow each country to go ahead with their efforts. And unfortunately, we've seen old reflexes of proprietary science patents and technological monopolies that took over. Each manufacturing firm has not accepted to share their technologies with CTAP or MPP. Even if governments continue to invest, if we continue to think that it's normal for vaccination, for vaccines to be monopolized by the private sector. Moderna, for example, has been 100% public investment, and it has monopolized its vaccine with a patent that it belongs to the firm. And there is abuse of the health system. Canada has set up in the summer of 2020 a working group on vaccination against COVID-19 to adopt a strategy to be able to go ahead with this. There's lack of transparency and conflict of interest by members of this group, expert groups, that has been noted, including by the microbiologist Gary Klobinger, who left the group. We also have seen that there have been recommendations from the working group that seems to give priority to the rights to the firms rather than looking for public health interests. And we've also been able to see that these companies are trying to see how they can sell their doses and as quickly as possible. And the priorities of, rather than looking at global health priorities, they're looking at everyone is looking out for themselves. Canada can do very well. They were able to get the greatest number of doses, 500% of their needs. And this is with respect to the agreements. Canada should be one of the first to get to immunity because of vaccinations. However, if Canada is doing well within this national vaccine game, it is also extremely problematic in a situation that there are delays with production with Pfizer, Biotech, and with AstraZeneca. And rather than having each country work towards an effort to produce the maximum of vaccines, we're looking at problems with global distribution. Canada does have the capacity to produce vaccines, so why are they not using that capacity right now in this war effort against COVID-19? Different countries, such as India and South Africa, have asked the World Health Organization to suspend the rights for copyright with respect to COVID-19 to be able to encourage a technological exchange and allow for greater production of the vaccine to put an end to this pandemic. However, Canada, United States, Europe, then UK, and Switzerland are opposed to this. And Canada seems to be rather part of the problem rather than part of the solution. I am available if you have any questions.
Thank you, Professor. We go now to the Honourable Paul Merriman, Minister of Health for Government of Saskatchewan. Minister, please go ahead. You have 6 minutes.
Thank you for the opportunity to speak today. This meeting had taken place a week ago. My message today would be much more.
I'm sorry, Minister. Your audio is broken up. It's distorted.
Still about a week ago, Saskatchewan had been receiving a steady supply of vaccines.
Minister, I'm sorry to interrupt, but your audio is distorted. Perhaps we can try it again without your video. Okay, thanks. Go ahead. I'll start you over.
If this meeting had taken place a week ago, my message today would be much more encouraging. Till about a week ago, Saskatchewan had been receiving a steady supply of vaccines from the federal government. While our provincial vaccine administration plan continues to be very effective, we are now virtually at a standstill with no vaccines delivered to Saskatchewan in over a week, and limited quantities now expected in the next few weeks. The vaccines we are receiving are going into the arms of Saskatchewan people as quickly as possible. Saskatchewan has the highest percentage of vaccines administered amongst the provinces, In fact, we now have administered 108% of the vaccines we have received. I know this sounds like a mathematical impossibility, but it's because our very efficient healthcare workers have been able to extract an extra dose out of some of the vials of the vaccine. I'll come back to that in a second. This efficiency has led us to a debate about relabeling the vials, a move that Saskatchewan certainly does not support. But first, I want to talk you through a brief history of our vaccine rollout to date in Saskatchewan. When Health Canada formally approved the Pfizer vaccine in December, we were ready. That same day, we announced our vaccine delivery plan. As with many provinces, it was based largely on the National Advisory Committee and immunization guidelines. Saskatchewan's Chief Medical Health Officer did some modifications to accommodate Saskatchewan's demographics and logistical requirements. Phase 1 of our vaccine delivery plan began on December 22nd, focused on immunizing priority populations who are at a higher risk of exposed to the virus and more risk of serious illness or death. This included certain frontline healthcare workers, long-term and personal care home residents and staff, seniors over 70, and all residents over 50 years of age in the remote northern communities. Due to logistical requirements of the Pfizer vaccine, we initially delivered it to urban centers that had the ultra-cold freezers. The Moderna vaccine was delivered to remote northern communities. We post Saskatchewan's vaccination numbers on the Government of Saskatchewan website and in a daily news release, so the public remains informed of our progress. Phase 2 of the vaccine delivery plan is expected to begin in April. This will be the beginning of our mass immunization. However, these plans are in jeopardy now. The Government of Saskatchewan's ability to vaccinate our residents is entirely dependent on a reliable supply of vaccine and a reliable information about the number of vaccines we expect to receive each week. Simply put, we need more vaccines, and we need more reliable information about when we're receiving those vaccines. The flow of information is almost as important as the flow of vaccines. Here's why. These vaccines are far more complex to transport, store, administer than, say, your annual flu shot vaccine. Our healthcare workers are absolutely up to the task, but as you know, Saskatchewan is a large province with many remote communities. So we need reliable information to plan appointments, transportation, refrigeration, and the deployment of our healthcare workers. When we have received the vaccines as scheduled, our program runs extremely smoothly. However, in the past few days, we have had sudden, unexpected schedule changes, causing us to have to cancel clinics in communities where they had already been announced. We need to ensure that everyone who receives their first shot is able to get their second shot in a timely manner. Again, this is extremely difficult to plan and execute without a reliable supply of vaccines and without reliable information. The announcement that both Pfizer and now Moderna are delaying expected shipments of vaccines to Saskatchewan has forced our government to revisit this plan. Saskatchewan's February 8th shipment is to be a third of what it was originally promised. Prior to the recent announcement from Pfizer and Moderna, we were only able to project to receive enough vaccines in the first quarter to fully immunize about half of our priority 1 people. Now, completing first and second doses for our priority population is becoming challenging. Simply put, Saskatchewan will not be able to vaccinate as many people as originally planned. Saskatchewan is asking the federal government to do everything they can to ensure the vaccines are made available as soon as possible, and that the province is receiving reliable information about vaccine deliveries. Information that is suddenly changing at the last minute is creating more challenges. Saskatchewan is also very concerned about Pfizer wanting to relabel their vaccine vials to say they contain 6 doses instead of 5, which will effectively be a result in a reduction of the number of vaccines the provinces are receiving. Health Canada should not allow this to happen. Earlier, I indicated that our healthcare workers have been able to get an extra dose out of the Pfizer. However, this should be viewed as an added benefit, not the standard for counting the number of doses. On average, we have been able to get a 6th dose, about half of the Pfizer vials. For a number of reasons, we cannot consistently count on getting that 6th dose out of every vial. That's why Pfizer should not be allowed to reduce its shipments to Canada by simply relabeling the vials and counting 6 instead of 5 doses. So my message here today is Saskatchewan is getting the vaccines into people's arms as quickly as we get them, but we simply need more vaccines. We need to get more reliable information about when we're getting those vaccines, and simply relabeling the vials does not amount to more vaccines. We all want this pandemic to be over and things to return to normal. That will happen when we have a significant portion of our population vaccinated. Our province and our healthcare workers are ready to do their part, so please just get them some vaccines. Thank you.
Thank you, Minister. So we'll start our questioning now. We will have time for one round. We will start with, I believe, Ms. Rempel-Garner. You have the first slot. 6 minutes, please.
Thank you, Chair. My questions will be directed to Minister Merrifield. Minister, you just said that you're only on track to have 1/2 of your priority 1 persons vaccinated by the end of March due to the supply issues. Is that correct?
That is correct.
So based on the current projections that you've been given by the federal government on supply, when would every person in Saskatchewan have access to a vaccine?
As it sits right now, we probably wouldn't be able to have everybody have access to the vaccine until later this fall. Our priority population is about 190,000 people, which includes healthcare workers, seniors. We're projected to only get about 110,000 of those vaccines by the end of March.
The assumptions that you've been told to make those projections on, do they rely on AstraZeneca and Johnson & Johnson's being approved?
No, these are just the Pfizer and the Moderna vaccines. We haven't got any information as far as AstraZeneca. In a conversation with the health minister, Minister Heidi, last week, they were saying that AstraZeneca could come on early, but we have nothing confirmed.
Has the health minister given you any sense of how many doses of AstraZeneca would be delivered to Saskatchewan over any period of time?
No, we haven't received anything official from them other than it's coming. But we've heard that about a lot of our vaccine shipments right now.
AstraZeneca has a significantly different delivery method than or requirements than Pfizer or Moderna. What kind of lead time would you need on that to be able to switch your delivery program?
Well, from what I'm told, the AstraZeneca is a much simpler vaccine to administrate, so we could get that one out a lot faster to some of our pharmacists and into our mass or drive-through clinics when we're able to open them. But it would be easier. The more information we know, the sooner is the better for us, so we can plan. We've got a lot of logistics to do in Saskatchewan to make sure that.
Has the government given you any assurances or formal assurances that there would not be an export ban or export restrictions from vaccines coming out of the European Union?
No.
Okay. How much do you think that will potentially affect supply if that comes to pass?
I would think it would have a huge impact on supply, and we would be down to next to nothing.
Okay. Have any of the details of the contracts, either with Pfizer, Moderna, or AstraZeneca, or Johnson & Johnson, been made public to you, specifically in terms of projected delivery schedules?
No, we haven't received anything.
Is that something that would be useful to you?
Absolutely. It would be very helpful to us to be able to see what's coming and what the quantities are.
Has there been any reasons given why those haven't been given to you?
They just haven't been provided. We've informally requested that, but nothing has been provided other than they say it's confidential.
Has the minister told you that the number of Pfizer doses that I guess they're contractually obligated to provide are now going to be dependent on that 6th dose? Have they given you sort of an indication that that's where the federal government is likely to go?
Yeah, that's the indication is they're going to relabel them from 5 doses to 6 doses.
So we're not talking about number of vials anymore. We're talking about number of doses with 6 doses in the vial. That's the indication that you've been given. Is that correct?
Minister Merriman, we're having trouble with translation again. Perhaps you need to cut your video again. Your video, sorry, your audio was very choppy.
Sorry, that was put me off my pace there. So the 6th dose. Do you have it adequate? My understanding is that there's a special syringe that you need to extract the 6th dose as well. Has the federal government supplied you with that on the assumption that there's going to be a 6 dose requirement?
We've been told that they're coming, but we haven't actually had any land in Saskatchewan yet.
Do you have any sense of when those would be arriving to the quantity that you need to distribute the vaccine?
We're hoping this week, but we'll wait until they actually arrive.
How much lead time are you getting from the federal government on understanding exactly how many doses you're getting per week?
We get a good lead time on what the projected doses are, but the changes come very quickly and they're always reduced.
My last question, last week in the House of Commons, the health minister gave a throwaway comment on the question of supply, saying that, using the example of Ontario, that there were doses left in the freezer. When you have supply disruptions with a 2-dose situation, I'm assuming that forces you into difficult situations about figuring out how to allocate future doses to new people versus meeting that 2-dose requirement window. Can you just give us a sense of how much the supply disruption has impacted the 2nd dose of high-risk populations?
In the high-risk populations, it's dramatically impacted this. We've had to change almost daily, and we're just always reacting on a very short notice to be able to find out when we can get this. If we don't get everything that we're promised right now, we will be in a challenging situation to get a 2nd dose to the people that have their 1st dose in the time frame that it's recommended.
Thank you.
Thank you, Ms. Rumpel-Garner. We'll go now to Dr. Belowski. Please go ahead, 6 minutes.
Thank you. Now, my understanding that the Prime Minister's statement that all Canadians who wanted a vaccine would have one by September is based purely on Moderna and Pfizer. And obviously, there's these other vaccines out there. We have the results of phase 3 large randomized controlled trials for both AstraZeneca and Johnson & Johnson and preliminary results from the Novavax study. They all look pretty good. AstraZeneca, when they mistakenly gave half the first dose, had 90% efficacy. Johnson & Johnson, I think it was Great Britain, was about 72% less than South Africa. But my understanding, 100% efficacy in preventing hospitalization and death, which is certainly very significant. Now, they all need approval by Health Canada, but certainly AstraZeneca and Johnson & Johnson are more conventional vaccines, and really the more novel ones are Moderna and Pfizer, which have already been approved. So I would think they're likely to be approved. Now, there's some concern about AstraZeneca and Johnson & Johnson not living up to that 95% efficacy of Moderna and Pfizer, but these weren't head-to-head trials. There were different populations. There was the new British variant. Also, I'm told with respect to Johnson...
Pardon me, doctor, you need to slow down a little bit for the translator.
Also, with respect to Johnson & Johnson's efficacy, Dr. Fauci has already stated with a booster that you could well get up closer to 90%. My understanding is, too, with AstraZeneca, with all the vaccines, you could add another booster to increase efficacy. So I thought, first, I'd like to comment on the relative efficacy of these. But more importantly, I know Health Canada has to do its due diligence and approve these vaccines, but what is the likelihood that they're going to get approved, and what will that mean in terms of time frames for distribution? And I know Dr. Bogash is on the Ontario Task Force on vaccines. What is your thinking in terms of how fast we'll be able to get vaccines out if and when these other vaccines are approved? So I'll start with Dr. Bogash, and then maybe Dr. Attaran can also reply.
So thank you, Isaac Bogash here. Those are great points and great questions. I completely agree with your points about looking at the relative efficacy of these vaccines because they're not direct head-to-head trials. And certainly the Pfizer and the Moderna vaccine were studied in an era that was not the variant of concern era. I also agree that the metrics we should be looking at don't necessarily have to land on protecting individuals from getting the infection, but mitigating severity of illness, limiting hospitalizations, and limiting deaths, which would be very, very successful metrics and would certainly be helpful and help us navigate our way out of this mess that we're in. Certainly, I think the newer technologies are also very useful because it's quite frankly plug and play. You can update your vaccine to reflect circulating variants and mass produce them in a rapid manner relative to older vaccine technology that takes a lot longer and has other issues that we don't need to get into on this call. There are publicly available documents for Ontario. As you point out, I do sit on the Ontario Vaccine Distribution Task Force, and certainly there are publicly available documents, and it's been mentioned several times in various mainstream media outlets of the program to roll out vaccination. Yes, there have been bumps along the road, but in general, when we have access to more vaccines, you will see much more widespread distribution. I don't think it's a fair comparison to say this is the same as influenza or measles vaccine distribution. There are true limitations based on the vaccines that we have and cold chain supply, cold chain issues. Having said that, all these plans involve, number one, distribution through primary care. Number two, distribution at pharmacies. Number three, distribution through mass vaccine sites. Number four, distribution through public health clinics. Number five, distribution through community centers, where some communities that might not be as comfortable with the government or healthcare in Canada will feel more comfortable going. And number six, mobile trucks and mobile units to help care for underhoused populations. That is part of the plan. Operationalizing it's another thing, but that's the plan.
Dr. Adarad?
Doctor, you're muted.
Sorry. All the vaccines are good. It's not worth getting into a question of which is the best. They're all good enough to use. The problem we have is getting more of them and getting it quickly, particularly now that it's become geopolitical. You know, in 1976, there was a swine flu epidemic, and the United States shut down exports of vaccines to Canada. So I hope in the next question I can get to the issue of manufacturing and how we perhaps stay safe from that.
Do I have time, Mr. Chairman?
You have 40 seconds.
Well, I guess maybe on that matter, I can ask Dr. Adarand. I know you've talked about domestic capacity. I know Mr. Gagnon has talked about basically, I think, compulsory licensing. What production facilities do we have in Canada that could ramp up production faster than the companies that are presently making them?
There are companies in Canada like Nuvax or Therapure that have biological molecule production facilities. For the cell culture vaccines, which is Johnson & Johnson and AstraZeneca, it's just a question of having cell culture capacity. And if we can't do that in Canada, it is the industry norm to do that with contractors now. That is the norm. We could simply hire one of the contractors like Emergent, like Lonza, like Fujifilm, and ask them to lay on another batch. And that would be a very simple negotiation, I feel. The lawyer in me feels with the company that is the patent holder, because you would essentially be asking them just to expand their contract manufacturing with an established contractor. And we pay the freight and we take the risk on the production. Why not?
Thank you, Doctor. We go now to Monsieur Thériault. Monsieur Thériault, allez-y.
We're going now to Mr. Thériault. You have 6 minutes. Thank you very much. I'd like to thank all of the witnesses for their contributions. Mr. Gagnon, thank you for having accepted our invitation. You mentioned earlier, and we experienced it in the Health Committee at the beginning of the pandemic, all of the experts and researchers said it was extraordinary, the collaboration that occurred, and I think that there was one to find a vaccine and to be able to create a vaccine. And now we've seen that there's been a race to acquire a vaccine, and we've seen that the wonderful collaboration and the sharing that occurred around the planet does not exist for the getting the supply. However, we do have a worldwide pandemic, and there are issues with respect to borders, and until all of the planet is immunized, it is going to be a problem, and the variants will continue. You said earlier that in certain articles that it was catastrophic, this way of working, that Canada has chosen its camp, you said. So how can we do different things differently to be able to get to a result that would be, in terms of public health, that would be a proof of solidarity, and it would be efficient? Well, thank you very much for your question. Yes, if we look at the AstraZeneca vaccine from the Oxford University. Initially, Oxford promised that this vaccine would not be exclusive and it would be free of rights. And so then they reversed their decision, and they went ahead with AstraZeneca with an exclusive license. And so AstraZeneca is number one, said that the problem was that we need to vaccinate the greatest number of people as quickly as possible, because in regions of the world where people don't have access to vaccine, the virus will continue to propagate, and it will mutate. And so now we have expertise. The expertise we have now will be less, may become obsolete, and will be less useful when new variants occur. But when AstraZeneca was asked if they would open up their patent so that this technology could be shared, so that there could be more manufacturers that would be able to use their capacity to be able to move ahead with this war effort, well, their answer was no. So these are some of the contradictions. AstraZeneca, if you look at the Pharmaceutical Accountability Foundation, which has noted recently that there is a company that it's very limited, this type of access that's beginning right now. You do have manufacturers who say that we're ready, and our production is ready to move ahead. But you don't have to just give us the recipe. We need the knowledge, all of the expertise. This knowledge has to be shared, and then we'll be able to contribute. However, this sharing of knowledge, there's huge hesitancy, a reticence to move forward with that. So what can we do? Well, what needs to be done is to be able to maintain a production capacity in Canada, first and foremost. And we can see that there are great public investment that is being done to be able to increase the capacity of production in Quebec. We've seen Intervac and the University of Saskatchewan also that has received a grant to increase their production capacity. But Canada also it takes its position internationally, saying that we want to open up these patents, but right now we are fighting a pandemic. Everybody wants to participate in the war effort, and so we shouldn't oppose any initiatives that are brought forward to be able to increase capacity. Is that not the only way that we can help in terms of the shortages? Without exaggerating, can we not say that somewhere this fall, from the point where pharmaceutical companies announced that they had an efficient vaccine, and that there were announcement after announcements that came out, maybe they took orders that they weren't able to fulfill, and we're stuck with that situation. And we have to be able to create a greater democratization of production so that we ourselves can produce, because we are going to need to modify these vaccines, and because of the variants, we're going to have to get a capacity for producing, and that's going to need to happen around the world. Well, yes, that's quite right. it's quite impressive to see that in terms of the development of new vaccines, there have been quite a few new vaccines that have been developed. But the question is, well, now, yes, there are confidential agreements between countries and the companies to have a rapid delivery. But what we're seeing that Pfizer biotech has had production problems. And what we've seen that with AstraZeneca, it is even more of a problem because you see there's a war between European Union and the UK. So if they want to be able to export to the UK through the WHO, they have to go through a specific process. So we're ending up with this trade war where the companies aren't able to respect the orders that they've taken, and the strategy of the different countries was to try and get to the front of the line to be able to get the doses. But if the doses aren't coming, then what do? Well, then it's too late to be able to look for new solutions. Even if there's good capacity, if you were to open the patents, well, then it would become much more available. Thank you very much, Mr. Thériault.
Mr. Davies. Mr. Davies, please go ahead, 6 minutes.
Well, thank you to all the witnesses for being with us today. Dr. Adoran, if I could start with you. You have stated that, actually last August, that the National Research Council knows how to make vaccines. Its brilliant scientists were the world's first to fully deploy an adenovirus vectored vaccine for rabies ahead of any pharmaceutical company. You have pointed out that the AstraZeneca vaccine is an adenovirus vectored vaccine. So I'm just wondering, how do you have any explanation for why Canada failed to negotiate the right to produce the AstraZeneca vaccine here in Canada, and how serious an omission do you think that is?
I think it's a giant omission. I mean, as you know, there are many different vaccine technologies. You mentioned the adenovirus-based vaccines. There are two of those. There's AstraZeneca and there's Johnson & Johnson, and they're among the simplest to manufacture. We could manufacture them in Canada. It is a question of having a large vat in which you grow the cells that produce the vaccine, then you purify the vaccine proteins, and then you formulate them and bottle them and all of that. We could do this in Canada. And contrary to the point of view that intellectual property is a big barrier here, AstraZeneca did license Brazil, Australia, India, and several other countries, to make its vaccine. And that has been done. Those countries are making the AstraZeneca vaccine. The intellectual property problems weren't that hard to solve. India is supplying it to its people as we speak. Brazil is rolling out the first doses this week. Australia, because they have so little COVID, they're taking it more slowly. But this is something Canada could do. And the failure of the government to negotiate to produce the AstraZeneca vaccine back in the summer, as Brazil was, India was, Australia was, Japan was, Mexico was, Argentina was, is a cardinal failure of this pandemic. Had we done so, we'd have something more right now.
Thank you, Dr. Gagnon. I'd like to move to you. Just in roughest terms possible, what percentage of the research dollars that went into developing these vaccines in Canada was provided by the federal government?
So in terms of the development of vaccines in Canada, basically the main project we had in Canada basically was this partnership with the Chinese company, and it didn't work. If you look at the global level, the contribution of different governments, basically more than half of the contribution in terms of investment are first and foremost public investments. But in Canada now, basically the new challenger in terms of vaccine is now with Medicago, and basically so it's still in clinical trials. But let's just say that that would be an interesting surprise if it can go through, because we would have here a very significant production capacity for this.
Thank you. Now, picking up my colleague, Mr. Terrio's questions, you have said that what we're seeing for you is a bit of a catastrophe, was your word. You said you end up with a handful of companies that are developing their own vaccines, each by themselves, working in silos. So then we have a product with a patent, so monopoly rights on the product. And then you end up with the vaccine nationalism of all countries, basically doing a free market negotiation in terms of who can jump the queue in order to get faster access to vaccines. In terms of priorities of global public health, this is pure nonsense. I'm wondering if we've got the model wrong. We have a global pandemic. We're talking in terms of war. I'm wondering if we brought a stick to a gunfight. Is using the private sector model of private companies monopolizing the patent and the intellectual property, is that the best way to get vaccines out to the world? And what would you suggest as a different model for that?
This is an excellent question. It's just, first, there are alternatives, and this is something very important. And we need to understand that the type of research and development that is being done in pharmaceuticals are requiring more and more for us to go outside the patent model. Basically, patents work very well for certain research niche. For others, it's not working well. And in a case of pandemics like this is very problematic because the amount of power we're giving to drug companies, because then we need to negotiate with these drug companies. And now we're negotiating basically, maybe not with a gun on the head, but basically with a needle in the arm. And then we need to decide, okay, what we're going to do. And we do not want to scare away the company by imposing some policy. So let's just say that if the focus was on open science from the start, basically, it would have been way more interesting. I just would like to add one thing. I agree with Dr. Adran that in terms of AstraZeneca, but AstraZeneca has been here a bit different than other companies. It's been the one who has been the most forward in order to go and do these partnerships with other companies around the world. But if you look at the different scoreboards with different companies, that's the only one who was so proactive in this. And with others, basically, it's all about preserving the expertise and knowledge they have.
Thank you. Mr. Kenya, India and South Africa.
Thank you, Mr. Davies.
Oh.
So I'd like to thank the witnesses. That brings an end our round of questionings. Thank you all for your time today and for sharing with us your expertise and your concern and care. And with that, we will bring in the next panel, and so we will suspend until that happens. Thank you all. Dr. Lexian. Welcome, and please go ahead, sir. You have 6 minutes.
Thank you very much for the opportunity to speak to the committee. I'm an emergency physician. I've been one since 1982. I taught health policy at York University from 2001 to 2016, and I've been researching pharmaceutical policy for about 40 years. So I'm going to go into four different areas. First of all, is the situation that Canada found itself in with respect to vaccine production at the start of the pandemic. Back in 1989, we sold off Connaught Laboratories to a French company. And then in 2005, ID Biomedical Corporation was sold to GlaxoSmithKline. Therefore, when the pandemic hit, we had no domestically owned independent production. We did have warnings that we might need it back with SARS in 2003, and then when H1N1 in 2009, the Naylor report after SARS recommended that we develop an independent vaccine strategy, but we never did. So when the pandemic hit, we were vulnerable when it comes to vaccines. In order to try and ensure that we were going to be able to get the necessary vaccines in June of 2020, the National Research Council set up an 18-member COVID-19 vaccine task force charged with making recommendations about vaccine acquisition to the federal government. Initially, the conflicts of interest of those committee members were kept secret until there was a public outcry. The task force was highly selective. There was no representation for Indigenous or Black people, the elderly, women, or people with disabilities, and both of the chair and the co-chair had significant conflicts of interest. Whether or not those conflicts of interest affected the recommendations that they made to the government are unknown, because the exact nature of the recommendations are not public. Other countries have handled this situation much differently, and in the notes that I submitted, you can see that Australia did things in a much different fashion. We're now faced with the delays in the delivery of the Pfizer vaccine and possibly others. The delays in different countries are different. That might be due to the terms of the contract that have been negotiated, but we don't know because the contracts are kept secret, and we don't know anything about the price that Canada is paying versus the price in other countries. What are the guarantees about vaccine delivery? And are there penalties for companies if they can't meet delivery schedules? Finally, I want to talk about Canada's position about ensuring vaccine availability and affordability in low and middle income countries. Canada is one of the largest donors to COVAX, and in July of 2021, Prime Minister Trudeau signed a letter along with other global leaders that said, amongst other things, we, the global community, cannot allow access to vaccines to increase inequalities within or between countries, whether low, middle, or high income. At the same time, Canada didn't support and still hasn't supported the WHO COVID-19 Technology Access Pool. It hasn't supported the call by India and South Africa at the World Trade Organization for a temporary suspension of patents and other intellectual property. It has not publicly demanded that companies making vaccines ensure that they are available at production costs, and it's not said when it's going to donate excess vaccines to low and middle income countries. I have 4 recommendations to make to the committee. First, Canada needs to develop a national vaccine strategy that will consist of a strong and enduring financial commitment to publicly funded and publicly run vaccine research. 2, we need a domestic, publicly owned vaccine manufacturing facility so that we can avoid the situation in the future of privately owned Canadian companies being sold to foreign interests. 3, is that time up?
Sorry, you have 1 minute left.
Okay.
Thank you.
3, Canada needs to make public the terms under which it granted money for COVID vaccine research and the terms of the contracts that it has signed with companies for vaccines. And finally, Canada needs to publicly outline a detailed strategy about how it will contribute to ensuring that vaccine nationalism is avoided so that low and middle income countries can access vaccines in a timely manner in line with their need. Thank you very much.
Thank you, Doctor. I forgot to mention at the outset that when you have about a minute left, I will display a yellow card, and
Okay.
when your time is up, I will display this. Okay.
Okay. Thank
the
you.
red card. Okay. Thank you. We go now to with the Canadian Public Health Association. We go to Mr. Ian Colbert, Executive Director. Go ahead, Mr. Colbert. 6 minutes.
Thank you, Mr. Chair, and good afternoon, honourable members of Parliament. Thank you for the invitation to appear before you today. On behalf of the Canadian Public Health Association, I want to begin by expressing our gratitude and support for the public health officials and health workers across our country involved in the response to COVID-19. In communities across our country, they are doing everything in their power in this unprecedented time to help Canadians stay safe and to give them the hope that there is light at the end of the tunnel. I'm pleased to announce that later this week, CPHA will be releasing its review of Canada's initial response to the COVID-19 pandemic. This report will provide a non-governmental perspective and overview of the public health measures taken to date. It is not meant to provide a detailed analysis of all actions taken, however. I will be pleased to provide the clerk of the committee with access to the review as soon as it is available so that it can be shared with members of this committee. The review will contain a number of recommendations on topics of interest to this committee and are relevant to addressing the second wave of the pandemic, including data collection, testing, contact tracing, and the need for a national approach to outbreak management. Whereas our data collection ended in mid-September, the review does not address the issues of vaccination that are of interest to this committee today. I will address some of these challenges now. Clearly, the COVID-19 pandemic is Canada's largest public health crisis in over a century, and we are seeing weaknesses in our systems as we attempt to secure timely delivery and dissemination of vaccines. Canada needs to develop the flexible, efficient, national research and production systems needed to reduce our reliance on international vaccine manufacturers and to meet the needs of Canadians while positioning ourselves as a good international economic partner. To this end, CPHA recommends strengthening basic and applied research capabilities to support infectious disease research along with vaccine development and production requirements. We also need to rebuild our domestic supply chains and manufacturing capacities for vaccine production. Finally, the federal government, in collaboration with provincial and territorial governments and other stakeholders, needs to develop, test, and implement national standards and strategies for the distribution of vaccines as part of our emergency response plans. This pandemic has also highlighted the limits of our healthcare and public health systems. Within government, the delivery of health services, as you well know, is the responsibility of the provinces and territories, with the federal partner having responsibilities for leadership, collaboration, and international relations, among others. The challenge is that the federal responsibilities for public health are not well defined through a policy, legislative, or regulatory framework. This situation must change if our country is to respond efficiently and effectively to future public health challenges. CPHA recommends the development of a more unified structure that provides a national approach to public health while respecting provincial and territorial responsibilities. This goal could be achieved through the development of federal legislation for public health, a Canada Public Health Act, with clear roles and responsibilities defined for all governments and stakeholders. Such legislation would require a national funding accord that incorporates performance measures for the delivery of public health services according to national standards. The pandemic has demonstrated the strengths, resilience, and weaknesses that exist within governments' collective abilities to meet the vaccination requirements of this country. Lessons can and must be learned from the past in order to end the current pandemic and provide the tools and capabilities to respond better to future emergencies. The current setback in vaccine deliveries is not unexpected. We are dealing with a novel virus, a new vaccine or new vaccines, new technologies, and new production processes. The manufacturers need time to expand their production facilities to meet the worldwide demand for vaccines. It must be viewed and conveyed to the public as an example of a short-term delay for long-term benefits. When I spoke to this committee last April, I noted that how we respond as individuals may be the single most important factor in how well we fare as a country. For as much as the hope of vaccines, that vaccines provides to us is the incentive to keep going, we have months of public health orders that we will have to continue to live through before this is over. So for better, for worse, how this is playing out is as we expected. This is a deadly virus that preys upon the most vulnerable in our communities. Now is the time for Canadians to continue to make personal sacrifices for the common good, and elected officials at all levels must set that example. This is an unprecedented situation. As such, our response is imperfect. I do not believe the Canadians expect perfection, but they do want to know that their elected leaders are working together with public health officials to solve the problems that arise. Thank you.
Thank you, Mr. Colbert. We go next to with the COVID-19 Immunity Task Force, we have Dr. Evans, Executive Director. Go ahead, Doctor.
Thank you very much for the opportunity to present today. I'll say a few words about Canada's COVID-19 Immunity Task Force. The task force was formed in late April 2020 by the Government of Canada with a 2-year mandate. Working virtually, the task force leadership group, co-chaired by Doctors Catherine Hankins and David Naylor, is a representative set of volunteer experts from across the country who are focused on understanding the nature of immunity arising from the novel coronavirus that causes COVID-19 and understanding the prevalence of the infection in the general population, as well as specific communities and priority populations. The task force and its secretariat have been working closely with a wide range of partners, including governments, provincial, territorial, federal, public health agencies, academic institutions, health organizations, research teams, other task forces, communities, and stakeholders. Most recently, the task force has been asked to take a major role in supporting vaccine surveillance for effectiveness and safety as the rollout of vaccines begins. Our overriding objective is to generate data and ideas that inform interventions aimed at slowing and ultimately stopping the spread of SARS-CoV-2 in the population. We have 4 areas of focus, which I will describe briefly. These areas of focus are being supported through 55 studies that are currently in the portfolio of the task force. First are seroprevalence studies that test for the presence of antibodies that indicate a previous infection with the virus, SARS-CoV-2. These studies are ongoing as we navigate the second wave. And these studies shed light on the level of immunity in the general population, as well as the level of immunity in priority populations, such as residents of long-term care facilities, healthcare workers, and racialized communities. Initial studies with the blood banks in Canada, for example, revealed that at the tail of the first wave of the pandemic in May, June 2020, the level of population immunity in Canada was extremely low, less than 1%. With a great endorsement, while that was a great endorsement of public efforts to limit spread of infection, these low levels of immunity made it abundantly clear that across the country, we remained extremely vulnerable to a second wave. Updated results in November 2020 in the midst of the second wave suggest that while levels of immunity have risen, particularly in the prairie provinces where they hover around 8 to 9% of the population, we are a long way from herd immunity. And as such, accelerated vaccination is an urgent priority to move Canadians towards herd immunity. A second area of focus is really understanding what immunity against SARS-CoV-2 looks like. How long does it last? And this science is happening alongside the seroprevalence studies. Results from one of the CITF-supported studies has just emerged, indicating that immunity following infection remains strong and protective for at least 8 months. As the cohort of infected persons are followed further, we will get more insight on just how long immunity from infection lasts. A third area of focus relates to immune testing, which includes, for example, research to validate dried blood spot specimen testing with made in Canada antibody tests that distinguish vaccine-induced immunity from post-infection immunity. These dried blood spot specimens can be used at home and are now being deployed in studies across the country to gather information about how population immunity is evolving as vaccines are rolled out. The final area of focus is the newest, and this is the focus on vaccine surveillance. The task force is supporting research partners from across Canada in a new collaboration that will monitor vaccine effectiveness and safety in the population at large and in high priority groups. Thank you very much.
Thank you, Dr. Evans. We go now to Medicago Inc. We have Ms. Natalie Landry and Mr. Petit. Petit. In any case, Ms. Landry or Mr. Petit, please go ahead, 6 minutes.
Thank you. Good afternoon, Chairman McKinnon, Vice Chair Rempel, Garner, and Thériault, and members of the committee. Au nom de Medicago, nous tenons à vous remercier le comité pour...
On behalf of Medicago, we would like to thank you for inviting us to this hearing.
Pharmaceutical company with a mission to improve health outcomes by using its innovative plant-based technology for rapid response to emerging global health challenges. Diseases know no boundaries. That's why Medicago is working tirelessly to develop vaccines to help prevent disease and to develop therapies to help treat those diseases. Of course, no disease is more prevalent right now than COVID-19. We are proud to be contributing to the fight against COVID-19 by developing a made-in-Canada vaccine that is currently in phase 2 clinical trial and with phase 3 to be launched in the upcoming weeks. Nous sommes une fière compagnie canadienne.
We are a proud Quebec company, and I'm sorry.
Ne va pas. L'interprète se plaint du fait qu'il y aurait des micros ouverts qui empêchent l'interprète de pouvoir bien entendre Madame Landry. Ça fait déjà un petit moment. Alors, si on pouvait remédier à ça, et je vous...
If we could please correct the situation that the interpreter has been saying that they're not able to hear Madame Landry, and so I think it's important that you be able to notice this before I have to interrupt the witness each time. So I think that we need to correct this for the next times, because it's very uncomfortable for me to have to interrupt, and I'm really sorry I'd like to say I'm sorry, apologize to Madame Landry.
I understand, Monsieur Thériault. I did not hear your point of order if you raised one. I'm not really in a position to know when there's problems with the French translation. So, I certainly welcome your intervention to say so when the time comes. I find actually with Ms. Landry switching back and forth between English and French, there's a bit of a gap between each time. So I wonder, Ms. Landry, if you maybe pick one or the other, we'd be probably better off. If that's okay with you. And we shall carry on, and hopefully, Monsieur Thériault, you'll get better translation this way. So please go ahead, Ms. Landry.
Et je m'excuse à l'avance.
Well, I'd like to say I'm sorry the majority of my notes are in English, so I'll continue in English.
Medicago uses a proprietary plant-based technology to develop a vaccine and therapeutics. Our vaccines are virus-like particles that mimic the shape and the appearance of the virus without being infectious and being able to cause any disease. And because they look like the virus, the human body recognizes them and raises an immune response. Our proprietary technology is extremely versatile and positioned to support a rapid response to pandemic. It has been developed to support the fight against pandemic threat and other emerging disease. As soon as the genetic sequence of a virus becomes available, Medicago can develop clinical grade material for a vaccine candidate in only a few weeks. An important feature for this pandemic as we see new coronavirus variants emerging. During the current COVID-19 pandemic, Medicago has reallocated nearly all its resources to develop a vaccine against COVID-19 and to accelerate its path to increasing Canada's domestic vaccine manufacturing capacity. In addition to our COVID-19 program, Medicago is advancing a number of programs in public health, including a pandemic and a seasonal influenza vaccine currently being under review by Health Canada. With respect to our COVID-19 vaccine program, I'm pleased to share some highlights of our phase 1 trial that is completed. The data have demonstrated that 100% of the study participants who receive an adjuvanted formulation of the vaccine develop high level of neutralizing antibody response and cell-mediated immune responses after the second dose. Our phase 2 trial is approaching completion, and based on these results and regulatory approval, the phase 3 will be launched in the upcoming weeks. The phase 3 portion of the trial will enroll 30,000 subjects in more than 10 countries to make sure that we have the diversity within our trial. And the result of this phase 3 study are expected during spring. And we expect regulatory approval for the vaccine during summer at the point where we will be starting delivering doses to the Canadian government. The Government of Canada's support has been instrumental for Medicago's COVID-19 vaccine development program and the construction of our large-scale manufacturing facility. It will ensure availability of Canadian-made vaccine to the population and provide much-needed domestic manufacturing capacity for vaccine, antibodies, and other immunotherapies. In addition, Canada's advanced purchase order of our vaccine has allowed Medicago to reserve supply for Canada and provide the security needed to pivot resources from other programs and to focus on COVID-19 vaccine development and production. I want to take this opportunity to thank government leaders and partners that made this investment possible. Public Health Agency of Canada, Innovation, Science and Economic Development Canada, Public Services and Procurement Canada, and the Government of Quebec. We are very grateful for your support and look forward to continuing to work with our government partners to protect Canadians from the current COVID-19 outbreak and future public health emergencies. As we look to critical factors involved in preparing for pandemics, it may be useful to structure our response according to 3 major axes: time, economics, and competencies. Pandemic response requires long-term planning, given the many years required to develop a vaccine platform and build domestic infrastructure. Private-public partnership provides strong synergies. While Canada needs to secure technology and domestic production capacity, industry requires terms to ensure sustainability and to encourage private investment. Competencies are critical to ensure a domestic response chain from early research to clinical development, production, and distribution.
Ms. Landry, I must ask you to wrap up ASAP, please.
Yes. So in conclusion, we wish to reiterate our appreciation to the Government of Canada and for its support. We are firmly committed to delivering vaccine to our population and serving Canadians to betterment of our national public health. And we will welcome any question. Thank you very much.
Thank you very much. So now we will start our round of questions. We will have time for one round, 6-minute rounds per slot. We will start with Mr. Barlow. Mr. Barlow, please go ahead, 6 minutes.
Thank you, Mr. Chair. And I'd like to direct my questions to Mr. Evans. Mr. Evans, on the Immunity Task Force, we recently found out that the Immunity Task Force was not able to complete your antibody testing to see just how prevalent COVID-19 is in Canada. It seems a lot of this was related to your inability to access serology testing because of Health Canada's delays on their approval. Do you think that there's been some serious bureaucratic hurdles that are preventing our country from having the best possible COVID-19 response?
Thanks very much for the question. You may recall or not, but when the task force was launched in April 2020, there wasn't a single approved immunoassay at that time, and the first approvals took place in May. Those were approvals for assays that required a blood draw, a formal blood draw from a vein. And we got those into the studies as quickly as we could. With respect to your question, I think the issue of looking at how to accelerate approval and the assessment of the efficacy of immunoassays is something that is important to do. I think this is not specific to Canada. I think in virtually every country, the standards for doing this, which involve assembling panels with diverse sources of blood, not only from infected people, but from people infected with other conditions, and the period over which one looks at those bloods, meaning not only when they're first infected, but 7, 14, 21, 28 days. That whole process, in my opinion, based on our experience, could benefit enormously from stronger standardization and discipline and coordination with respect to making it work much more efficiently. A second point I would make is that we did not have any point of care assays approved by Health Canada. Those are assays that can be used with a drop of blood from the finger. And these assays can be used at home. And so this allows you to test populations in a much easier way than to have people come and have a formal drawing of blood with a needle. We worked very hard in the National Microbiology Laboratory to get an assessment of the validation of the dried blood spot. And this we achieved in September. But this, again, is an area where I think if we looked at the process of getting to the accreditation or the authorization that this was a valid and useful test, I'm sure there's room for improvement. So short answer is yes, I think there's room for improvement in terms of getting our testing assessed for accuracy more quickly.
Mr. Barlow, you're muted.
Sorry, Mr. Chair. Mr. Evans, do you know what our national capacity is to test for the variants? Do you know what our capacity is to test for the variants?
The short answer is I don't know the exact capacity. I've been part of discussions with an effort to mobilize capacity for tracking the variants, and it's multifaceted, related to sequencing capacity and also linking this to follow-up of the implications of the variant in terms of its impact on transmission, as well as the disease profile of people who have those variants. but I'm not in a position to comment on the scale of that capacity at this point in time, other than to say I've been part of conversations where it's being, where plans are underway to scale it up.
So, Mr. Evans, just on that, is it adequate or not? In your opinion, is it not adequate? Just if you can give me a quick answer there.
I think Canada has very impressive sequencing capacity through a set of institutions, and I think that once they join together, we should have that capacity certainly across the country.
Last question, Mr. Chair, to Mr. Evans again, but how can we understand immunity if we can't test for those variants? How are we going to set that baseline if we can't test for the variants that are emerging?
It's a very good question, and I think what we're looking at is to understand what the immune implications are of the variants. And this is a combination of one, observing the patterns of the variants in the population in terms of what their impact is on transmission and on the disease pattern, but also carrying on more laboratory-based studies that help us to understand how these variants might act differently from the other forms of the virus that we've been looking at thus far. So I think everyone in the world is in a similar place on this front. And there's an opportunity, not only in Canada, but globally, to draw on that scientific enterprise to understand as quickly as possible what the consequences of these variants are for immune protection.
Thank you, Mr. Barlow. We go now to Ms. Sidhu. Ms. Sidhu, please go ahead. 6 minutes.
Thank you, Mr. Chair. Thank you all the witnesses for being here. Federal government is still expecting to get 6 million doses by the end of March with the 2 vaccine presently authorized. We expect that 13 million Canadians will be vaccinated before the summer. And we are on track to reach our target 70 million doses by the end of September. Of course, this will go faster as even more vaccines are authorized. That is why we are hopeful they will be. So my question is to Mr. Colbert. Vaccines are being administered by hospitals and public health agencies. As the supply increases over the coming weeks, do you think the agencies will be able to keep up with the demand, or do you think that the locations of delivery, like pharmacies, doctors' offices, will need to be utilized?
Thank you for that question. I think first it depends on which vaccines we're talking about. Certainly the need to track and have in electronic registry a record of who has been vaccinated, scheduling their second dose, and being able to track any adverse events is going to be crucial. My concern about increasing the number of tracks of potential sites for vaccination is that it's that many more systems that have to be brought on board to track that information. I would support a greater investment in mass public health vaccination clinics in multiple sites, but organized by public health, and bringing in as many vaccinators as you can. So if pharmacists want to be part of the vaccination movement, they should be, but under the umbrella of public health run mass vaccination clinics.
Thank you. During the last panel, Dr. Bogash was talking about the issue of vaccine hesitancy. Unfortunately, vaccine hesitancy is a problem among some visible minority groups. Misinformation spread easily on social media, and official public health information is not always available in the necessary languages. Can you speak to how public health agencies are combating misinformation and vaccine hesitancy, especially among multicultural communities?
Certainly, frontline public health organizations have links to those communities established. They work with them on a regular basis. And so we'll be getting allies into community centers or other venues. It's hard to have large groups, so it's more one-on-one. But the ability to connect directly with those populations is absolutely crucial, and will be going forward, that they hear both a message from someone who looks like them, who represents their interests, but also has sufficient background to be able to answer their questions.
Thank you. And Dr. Evans, our government has provided over 17 million rapid tests to the provinces, territories. Ontario has received over 6 million of those tests. But according to updated numbers provided by the province Ministry of Health on Monday, it had deployed only about 1 million of those tests. My community of Brampton has been one of the hardest hit and is home to many industrial and manufacturing hotspots. Do you think increased usage of the rapid test would help to control outbreaks? And can you provide any explanation as to why the province has been so reluctant to use them?
I'd just like to clarify in answering your question that the COVID-19 Immunity Task Force is not focusing on testing either with antigens or with the real-time PCR, RT-PCR. However, I would say that the evidence from across countries is that where you have not only more aggressive or higher levels of testing, but also much more timely determination of the results and follow-up of contacts, those countries are in a better position to control the epidemic. So I think, again, in the spirit of learning, Canada has a lot to learn in how to manage testing systems such that they get to the populations where the problem is greatest, and they're managed in such a way that you get timely results and can mobilize contact tracers in a way that you can mitigate spread of infection. Having said that, we need to look to our Atlantic provinces where I think there's significant evidence of very good practice on that front thus far, but also take advantage of the way in which testing systems have been deployed in other countries.
Why I'm saying that, recently 3 Amazon facilities in Peel announced that they will be conducting their own rapid testing, which is helpful, as getting a test can often be a hassle and confusing. Of course, not every company has the financial resources that Amazon does. Should the provincial government be deployed their test to essential workplaces to help them control outbreaks?
My personal opinion on this is that getting more disseminated testing according to very clear public health standards is the only way to reach the levels of testing that are necessary to really mitigate the spread of infection.
Thank you, Doctor. Thank you, Ms. Sadu. Nous allons maintenant à Monsieur Thériault.
We'll now go to Mr. Thériault. You have 6 minutes. Thank you very much, Mr. Chairman. I would like to thank the witnesses for their testimony. To manage such a crisis, a health crisis that we have now, it implies that we need to be able to have the population really follow all of the measures that that are put in place, and they also have to have a trust. And since the announcements at the end of December for promising candidates for vaccines and now authorized vaccines, we have felt that there was a difficulty and a certain fatigue in terms of maintaining the rules. Things were somewhat more relaxed. And I think that happened over the summer, and we saw that practices over the summer were changing. But this is for Dr. Lexine. Is it normal that now, if we want to maintain the trust in the authorities and for the population, in September 2021, with the numbers that we have, can we really say that we'll be vaccinating everyone who wants the vaccination at the same time as that things are completely dark in terms of the deadlines for delivery? And so with respect, everything that we know with respect to the question we know the volume, we don't know the price, we don't know what are the conditions, we don't know what the schedule is for delivery, but we're being asked to believe that everybody can be vaccinated between now and September 2021. What does that all mean?
First of all, I think that what we're dealing with is a lack of domestic capacity to produce vaccine, which leaves us vulnerable to what's going on in other countries. We're seeing now threats or moves by the European Union to possibly restrict the export of vaccines from those countries. Those are issues that we don't have any control over, nor do we really have the information to know what's going to be happening with delivery, because we don't know anything about prices. Based on leaks from other countries, we know that there are differences in prices that have been negotiated. So for instance, the UK and Israel seem to have negotiated higher prices than the European Union, which may be affecting how quickly companies deliver to the European Union. We don't know the prices that Canada has paid. And this lack of information is a significant deterrent to being able to understand what our capacity is going to be able to vaccinate people over the coming months.
Monsieur Evans, avez-vous des...
Mr. Evans, do you have simulations with respect to the steps, with respect to herd immunity? We start with vaccinations, that has started, but with respect to the announced forecasts for vaccinations, everybody may get vaccinated by September 2021, but that doesn't necessarily mean that we'll have attained herd immunity. Are there any simulations done with respect to herd immunity that are done by you? At what point do you think that we will get to herd immunity? And given the fact that now almost no one has received the vaccination, is it not necessary to maintain and to even strengthen all of the health measures that are in place, and that for quite a while?
Pour la question, qui est très, très important à ce moment.
Thank you. Thank you very much for the question. We don't have a model that will tell us exactly when we will achieve herd immunity, which will mean that the rate of reproduction of the virus will be under 1. But we are working on building these models at this point in time with people who are experienced with this type of forecasting, but also we are trying to get the schedule for the vaccination. And as you know, right now, this schedule is still difficult to foresee or to know, given the conditions at this point. But I simply wanted to say, with respect to your second question, it's absolutely essential that in the next 6 months, that all of the protections protection measures are followed by the population. And so it would be dangerous as long as we don't have this type of modeling. We can't imagine that we should lighten any of the health measures that are in place. Answer, Mr. Evans, I think that we have to be very careful. There are always things that can't be foreseen. And there can be changes in how over the next 4 to 6 weeks, we may be able to see some kind of change in policy with respect to forecasting. But I think for now, it would be very prudent and necessary to maintain all protective measures that are put in place by public health. Question, so that we would have to increase tracing. Thank you very much, Mr. Thériault.
Now to Mr. Davies. Mr. Davies, go ahead, please. 6 minutes.
Thank you, Dr. Lex Chin. I'm going to start with a couple of accountability questions and get into some substantive ones, if I may. It's well known now that the federal government refuses to release a single word in a single contract it has signed of the 7 vaccine manufacturers that it has contracted with. Do you see any legitimate reason for the government's refusal to reveal to Canadians any details at all in these public contracts?
Thanks for the question. I think that what the problem is that the vaccines are being treated as commercial products subject to commercial contracts. The vaccines are not a normal commercial good in the sense that computers might be. They're essential to health, and because they're essential to health, we need to understand the terms of the contract so that everybody is aware of what the delivery schedule is going to be, the number, how quickly those doses are going to arise. So I think that Canada is just following what other countries have been doing or have done in terms of treating this as commercial goods. And I think that's a fundamental failure of the global community, not just Canada's.
Okay, now I'm going to get to that in a second, because I think that's a very important area. But you know, we've been studying this subject for almost a year, and we've had very few questions about the vaccine task force. But you brought up this issue of conflicts of interest. I want to read you something that was written just a few weeks ago about it. It says, "An important issue in the medical arena is the ubiquity of conflicts of interest at play, and how we consider this to be almost normal. Public transparency of conflicts is not enough. Independence is what is required for Canadians to gain trust in vaccine decisions. It is therefore mind-boggling, for example, that the task force decided that co-chair Mark Leibinen, who was the CEO of Sanofi Canada for 17 years until 2016, who still owns shares in Sanofi, who is consulting with drug companies, and who remains the director of 2 other drug companies, had no direct material conflict of interest in assessing the Sanofi vaccine." So in your view, Dr. Lexchen, has the Federal Vaccine Task Force demonstrated sufficient independence and openness? And what can you tell us about the way they've decided to conduct their activities essentially in secret?
That's certainly a significant problem, is the lack of transparency. I mean, one of the things that we've been faced with over the entire period of the pandemic is that we need public trust in what is happening, what the health community, what the government is doing in terms of trying to protect us from COVID-19. But without transparency in terms of what's happening on the task force, that trust is being eroded, and it can be done much differently. So in Australia, for instance, back in April, the government in Australia funded a national COVID-19 clinical evidence task force to provide rapid evidence-based and continually updated advice on Australia's response to the COVID-19 pandemic. And it set up an independent committee of 4 people to give advice over who should sit on this task force, release their conflicts of interest to this independent committee. The independent committee provided advice back to the Australian government saying, no, this person shouldn't be sitting on the task force. Yes, this person's okay. And the Australian government has been following that advice, ensuring that when they get information from the task force, it's not tainted with possible conflicts of interest.
Thank you. Now, I want to put two scenarios by you, Dr. Lexgen. From an epidemiological and public health infectious disease point of view, if we could immunize all 7 billion humans in the next year versus not doing that, but rather, say, immunize only a quarter of the world and do the rest over the next 10 years, does that have any impact on the ability of this virus to mutate, or is it beneficial public health point of view to do one over the other?
In my view, what we need, what we want is a global strategy for this, so that the most vulnerable people in all countries get immunized to decrease the rate of spread. One of the things that we know is that the faster the virus spreads and the more people it infects, the higher the likelihood that it's going to mutate. And that's why I think one of the reasons we're seeing mutations coming from countries like Brazil, South Africa, and the UK, and possibly there are mutations in the United States. These are places where the virus is spread very rapidly and widespread. So if we concentrate our immunization efforts, as we seem to be doing, on the rich countries, and then go to the low and middle income countries, what we're doing is we're ensuring the development of mutations. Some of those mutations may be resistant to vaccines. So what we need, and I think what we need Canada to be doing here, is showing leadership. Canada can't do this alone, but it can certainly show that other countries what the right course to do is. And I think that the right course is for Canada to support the COVID-19 technology pool, give more support to COVAX, and announce when we're going to be donating our excess vaccines to other countries.
Now, did you not say that South Africa and India are calling on the WTO?
I'm sorry, Mr. Davies, your time is well past up. So
really?
Yeah, you're at 6:49 here, so.
Okay, thank you.
Thank you. So I'd like to, that brings.
Mr. Chair, you're on mute.
Usually better. Okay. So I'd like to thank all the witnesses for sharing with us their time today and their expertise. And you know, your input is extremely well appreciated and will be most helpful to our study. With that, I would invite the witnesses to withdraw, and we will carry on with a little bit of business left over from Friday. So on Friday, we were considering a motion by Mr. Van Bynen. At the point where we moved to adjourn until now, we were perilously close to, I think, achieving a meeting of minds. So Mr. Van Bynen's motion was to instruct the analysts to prepare a report on the mental health study. It was simply instructions to prepare a report. There was no mention there of taking any time, committee time for considering the report. Mr. McGuire submitted a motion to amend that to require that any consideration of such a report could only be done during a constituency week. So I see hands up on the side. I have Mr. Van Bynen up first. Mr. Van Bynen, please go ahead.
Thank you, Mr. Chair. Let me start by thanking my colleagues for proposing that we continue this debate today after we've heard from witnesses on our second topic under the current study. Hopefully, everyone has had some time to think about what I proposed last week. I hope we can get to an agreement and continue to be productive in our roles as members of this committee. With respect to the standing committees, the House of Commons Procedure and Practice, 3rd edition, 2017, Chapter 20, page 979, indicates that each committee is given the power to examine and inquire all such matters as the House may refer to it, to report from time to time, and to print an appendix to any report after the signature of the chair containing such opinions or recommendations dissenting from the report or supplementary to it, as may be proposed by committee members. And on Friday, January 29th, I proposed to you, my colleagues, that we, committee members, instruct the analysts to prepare an interim report on the topic on the impact of COVID-19 on mental health of Canadians, based on the 4 meetings held on this topic as part of our current study. We were instructed by the House to look into, excuse me for a second, Mr. Chair, my notes seem to have frozen. Here. We were instructed by the House to look into the emergent situation facing Canadians in the, just a second, in the light of the second wave of the COVID-19, to hear from Canadians across the country and the impact this has had on our lives. I'm having some technical difficulty. I think it's solved now. Thank you. And to study the government's response to the coronavirus pandemic. As such, our committee agreed to a plan. Each party would submit 4 topics in the study in order of priority. Each topic would be examined in turn by priority on the following rotation: Liberal, Conservative, Bloc, and NDP. We determined by majority that the number of meetings per topic, with a minimum of 1 and a maximum of 4 meetings. Each party would be entitled to an equal number of witnesses. Now, this is a Sparks note or a Coles note version of it, but I'm sure the clerk, the analysts, or the appropriate person would be more than happy to send an email to all members with a reminder to what was agreed upon in this plan. If I remember correctly, it was Mr. Davies that suggested our committees move forward in such a manner and move the motion which outlined our current plan. So maybe he's able to give us a better summary of it than me. But I do know, however, at that time, I said it was a reasonable approach, and I still believe that to be the case. However, I have since come to realize that interim reports as part of our study will help, not hinder, as it was suggested on Friday, our ability to effectively work as members of the Health Committee in the pandemic. I will once again quote our favorite book at this time on page 991. In order to carry out their roles effectively, committees must be able to convey their findings to the House. The standing orders provides for committees with the power to report to the House from time to time, which is generally interpreted as being as often as they wish. As the Standing Committee on Health in the middle of a pandemic, I see creating interim reports on each topic of this current study as our duty to the House, to the task that we've been given, to our colleagues and to Canadians. I want to be very clear, because perhaps I wasn't on Friday. I'm proposing the analysts produce an interim report on the topic we had just finished. I'm not proposing that we stall witnesses on vaccine delivery or the ministers in front of the committee next week. I'm not proposing that we interrupt, impede, or delay any of the meetings on the topic or vaccines or future topics. I want to remind you that all parties submitted the topic of vaccines as a priority. I'm not asking analysts to take any time away from the work in the meetings on the topic of vaccines or any future topics to write an interim report. On Friday, I asked our analysts their thoughts on this, and the answer was clear, and I quote, "I think writing an interim report would be very helpful. It would be helpful, it would help the committee to focus on what they heard during those first 4 meetings, and it takes the study into some easier to consume bites. We're fine to go ahead and start to draft an interim report, and if the committee wishes, each of the members could submit what they hope to be in the report. That could be submitted through the clerk. The House of Commons procedures and practice is clear on reports. They say they may be short documents of less than 1 page in length or more substantial and separately bound works. Page 990, if anyone would like to check. So I see no problem in us being able to provide our requests and recommendations in writing through the clerk. I am also not asking us to, quote, be wasting meetings deliberating like punctuations on the report that's not material to the tools getting to the end of this pandemic, end of quote. I'm confident in our analysts' ability to punctuate properly, as well as to dot the I's and cross the T's, and to question our analysts' ability to proper punctuate is offensive. As is insinuating documenting our work is not material to getting tools to end this pandemic when it very clearly is the opposite. It's unacceptable that 1 year, 36 meetings, 198 witnesses, and 63 submitted briefs since our first committee meeting relating to COVID-19 that we have not yet reported our findings and recommendations to the House. So, Mr. Chair and colleagues, I'm once again seeking agreement on how to find a way for our analysts to produce an interim report. We just wrapped up the meetings on one topic. Let's have an interim report on that. And once we wrap up the next topic, let's have an interim report on that, and so on. This is a large study. It encompasses a variety of important topics for me, my constituents, you, and yours. Let's make sure that the witnesses we bring in, their testimonies, their requests, and the questions we are asking are reflected and reported in a timely manner, without impeding, interrupting, or delaying the following topics. We're all professionals here, and I trust that we can work together to find a solution to move this forward. Thank you, Mr. Chair.
Thank you, Mr. Van Bynen. We now have Mr. Killaway. Go ahead.
Thank you, Mr. Chair, and hello to my colleagues. Like MP Van Bynen, I reflected on Friday's committee meeting over the weekend. And I think it's pretty clear, at least from my perspective, and I want to break it down a little bit, and I'll promise to be only a few minutes. I believe there's consensus. That being an interim report would be great, but it seems to me we're on the fence or just can't decide on what the topic should be. Like I said last week, none of us on this committee have any intention, zero intention of delaying a vaccine study. We're simply suggesting an interim report be written on a concern for millions of Canadians, which is mental health. Now, no one is saying that when we conclude the 4 meetings or 5 meetings, if you include the minister's appearance, that we can't do another interim report on vaccine and so forth and so on. All members of this committee know how important the mental health study is to Mr. Van Bynen, to all of us. It's important to Canadians. And it would be great to work on this together. So last week, I think, and I hope I have this right, Ms. Norris said, we can check the blues on this, that an interim report would be helpful and really allow the study to be produced in easy to consume chunks, as Mr. Van Bynen referred to. And I look at that as a real practical and effective approach, in my opinion. So, Mr. Chair, I'm wondering, we have the analysts here. We have the researchers here. Can we include them in this conversation? After all, they're part of Team HESA. Thanks.
You're muted, Mr. Chair.
Sorry. If the committee agrees, I can ask the analysts to step in here and give a response. Is there any opposition to that?
Yes, Mr. Chair, I think we should hear from more than just the Liberals on the committee before we hear from the analysts. There are different perspectives on this matter.
Okay, well, we'll carry on. We have Mr. Fisher next.
Thank you, Mr. Chair. I don't really have everything that I was going to say was already said, and I think Mr. Davies is right. We'll hear from members of the opposition, and I'm glad that Don. I think Don's up next. I always like hearing from Don and trying to find a way that he finds a hybrid for what we're all saying. So I'll put my hand down. Thank you.
Thank you, Mr. Fisher. Mr. Davies, please go ahead.
Thank you, Mr. Chair. Well, I do think I will have a suggestion, but I think it might be a better approach forward. A couple preliminary remarks. I don't think interim reports are a bad idea, particularly given the current issue before us. I must say in 12 years, I don't recall us ever doing one. I've never done an interim report, and that includes some very lengthy studies too. We studied pharmacare for, as Mr. McKinnon and Ms. Sidhu will remember, for a good 2 years. We didn't issue an interim report in that. Having said that, I'm not opposed to the concept of an interim report. The question really is what should that interim report be on? Now, of course, we opened this study back in February of last year, and we heard a lot of evidence from February to, I think, into mid-July, when the committee stopped sitting, on many issues, and some of those were extremely important issues. We heard, today on vaccines. We've heard about issues on domestic production, transmission reduction strategies, the impact on racialized communities. Many. In fact, today, I think we've heard some evidence on an extremely important issue, which is the world even using the right model to get vaccines to the population? We're using a private corporate commercial model that is clearly unable to get enough vaccines to people instead of a global approach. So the question really is out of all those things, should we issue an interim report on mental health based on 4 meetings that we just heard? Now, I think mental health is important. I think it's as important as many of the other issues I've mentioned. But I'm not sure that it's more important than many of the other issues that we've heard about. So the other thing, of course, is what Mr. Van Bynen's motion is really asking is for this committee to issue a report on an interim report on mental health based on 4 meetings that happens to be the priority of the Liberal Party, and to issue that report. Although we're all interested in mental health, that was the Liberals' choice for the first priority, and we have not heard the first priority of the other 3 parties yet. I very much like, if I understand correctly, and Mr. Theriault can correct me if I'm wrong, any error in reciting this is mine, not his, but if I understood his approach, I prefer Mr. Theriault's approach, which is if we were going to issue an interim report, what I would like to do is have the analysts summarize all of the evidence that they've heard to date, and then wait until after we've at least heard from each one of the 4 parties' first priority, which will take about another maybe 30 days or so. And then we issue an interim report that summarizes the evidence to date in a global, comprehensive way. And at least it's fair because we've heard from all 4 parties' first choices, not just the Liberal parties. I would point out as well that, although I don't think this is a big deal, we were hampered a little bit by the prorogation. I don't think it mattered a great deal, but we did have to, it did cause the committee to lose 3 or 4 meetings to get up and running again back in September as we had to rejig. So I think what that's done is it's made us kind of forget a little bit of the incredibly profoundly important evidence we've heard on profound issues of importance to Canadians from February till now. I would say as well that I also trust our analysts very, very much, but this committee time will be taken up in reviewing a report. We have to. We can't just say to the analysts, go write a report and then issue it. The report has to come back before this committee, and we are obligated to go through that report line by line and have debate and discussion and amendments on that report. So that will take committee time. Now, I'm not necessarily opposed to doing that, except for I don't want to be doing that now before we've even had a chance to hear from the Bloc or the NDP on our first priorities. So for those reasons, I'm not in favor of this motion at this point. But I would suggest that maybe we can go back and think about this, that all members of this committee reflect on the suggestion that I've made in this, which is why don't we wait and hear from the first priority of all 4 parties in the first round, and then we can, perhaps even now, we can instruct the analysts to begin the very laborious process of summarizing the evidence heard to date, which has to be done at some point. And then we can revisit this issue and discuss issuing an interim report after we've heard the first priority of the 4 parties. My final comment will be this. I have great respect for this committee, and I think when we speak with a force to the Parliament, but we are fortunate in having the Parliamentary Secretary to the Minister of Health serving on this committee, and that's Mr. Fisher. There is nothing preventing the Liberal members of this committee or Mr. Fisher from going to the Health Minister at any time. They sit in caucus every week with the Liberal Party, the governing party, and to be bringing this information to the government to influence policy. The government does not have to wait, and in my experience, they generally don't actually listen to what the Health Committee tells them to do in any event. I mean, this committee issued a majority report urging the government to in a timely way, bring in public pharmacare. That was 3 years ago. We can't even get the Prime Minister or the Health Minister to even commit to the concept. So for all those reasons, I'm going to vote against this motion, but I do like the idea of an interim report on a broader array of issues, not limited just to one issue, which, as important as it is not the only important issue facing Canadians. Where I'll conclude is, if there was one issue that I think we should be issuing an interim report on right now, it should be on vaccines. And the reason is because it's vaccines that are going to actually provide the answer, as we've heard from these witnesses today, to the health crisis facing us. The mental health issues are a derivative. It is a secondary impact of the fact that people are dealing with a pandemic out of control. So if there were a need for an interim report and advice to government on anything right now, to me it would be on giving that government advice on how it can expedite the delivery of vaccines to Canadians, because if we do that, I think you will start seeing amelioration of the mental health impacts to some degree. So those are my comments on the motion.
Thank you, Mr. Davies. I'd like to clarify, however, that Mr. Van Bynen's motion did not ask to issue a report, only to instruct the analysts to prepare one. We have Mike, Mr. Kellaway next. Please go ahead.
Thank you, Mr. Chair. Everyone calls me Mike, so please do. Don, thank you for that. And I'm just, playing with wording on my screen here, but if I wonder if I read something to you, and by no means is it something to commit to at this moment, but I just want to make sure I got what you're saying. So if we amended the motion to instruct the analysts to prepare an interim report for each of the topics of study as we conclude their meetings, and for them to be reviewed at the end of the first round of topics, is that where you're heading with it? I just want to make sure. Through you, Chair, to Mr. Davies.
Mr. Davies, did you wish to respond to that question?
Yes, thank you. Well, thank you, Mike, for that question. That's one derivative. I mean, I actually hadn't put it that finely, but that's another. I think it's a fairer issue to perhaps do an interim report just on the first 4 priorities. What I was saying was to summarize all the evidence heard to date.
Okay.
But that's another. I think your suggestion, Mike, is one that would be worth considering too.
Thank you.
Thank you. So I see no other hands up to speak. I should remind everyone that the vote at this moment is on Mr. Maguire's amendment, which is to require that any consideration of the report mentioned in the main motion would not happen except on a constituency week. So still seeing no hands raised to speak, I will call for a vote on Mr. Maguire's amendment. All in favor of Mr. I'll ask the chair the clerk to conduct the vote on Mr. Maguire's amendment.
Mr. Fisher?
Est-ce que, Monsieur le Président, on pourrait...
Mr. Chair, could we go over that, give us a quick reminder of that amendment?
So, as I mentioned earlier, Mr. Van Bynen's motion was to ask the analysts to prepare an interim report. Mr. Maguire's amendment was that we restrict any consideration of such a report to strictly to constituency weeks. Is that, are you clear now on what we're doing, sir?
C'est juste sur le temps.
So it's only with respect to the time of work. It doesn't have anything to do with the discussion that we just had. It's just to say, if the amendment is simply to say that if there were to be such a report, we would have to look at it outside of the parliamentary calendar. Okay, well, that has nothing to do with the discussion that we just had. It just occurred.
Because if we pass Mr. McGuire's motion, and then if we pass Mr. Van Bynen's motion, then we will instruct the analysts to prepare a report, and that such a report, if and when we choose to consider it, would have to be done during a constituency week. So that's the upshot of the motion and the amendment. I see Ms. Rempel, you have your hand up.
Thank you, Chair. I think Mr. Davies raised some good points for me. The mental health study, I think the testimony that we got was just devastating. It really showed the impact of the continued prolonged lockdowns, the impact of not having an adequate vaccine supply, of not having rapid tests. And I think it really sets the scene for some of the recommendations that I expect will come forward in the vaccine component of the study, perhaps rapid tests. So I'm comfortable actually, to Mr. Theriault's comment, I'm comfortable voting against Mr. McGuire's motion and then against the main motion as well.
Thank you, Ms. Rempel-Garner. Okay, so again, seeing no hands raised, I shall ask the clerk to conduct a vote on Mr. McGuire's amendment.
Mr. Fisher?
No on the amendment.
Mr. Kellaway?
No on the amendment.
Mr. Pawlowski?
No.
Ms. Sidhu?
No on the amendment.
Mr. Van Bynen?
No with respect to the amendment.
Mr. Barlow?
No, Mr. Clerk.
Mr. D'Entremont?
Nope.
Mr. McGuire? Mr. McGuire? Ms. Rempel-Garner?
No.
Monsieur Theriault?
Non.
Mr. Davies?
No.
So, yeas pour 0, nays contre 10, 10.
Thank you, Mr. Clerk. So Mr. McGuire's amendment does not carry. We go now back to debate on the main motion. I see we have Mr. Kellaway. Please go ahead.
Thanks, Mr. Chair. I'd like to take this time to move to amend the original motion to instruct the analysts to prepare an interim report for each of the topics of study as we conclude their meetings, and for them to be reviewed at the end of the first round of topics.
Thank you, Mr. Kellaway. So we now have a new amendment on the floor. Ms. Rempel-Garner, did you wish to speak to this amendment?
I do. I would just assume, Chair, that it's standard practice that the analysts, I mean, in my 10 years of being in Parliament, analysts are preparing a summary of evidence and working on the report while witnesses are coming forward. I guess I'm not sure what this amendment would do. The other thing that I would also note is that the situation that we're facing is almost changing daily, with it getting worse. I'm concerned that if we're just coming up with interim reports like right now, and that's like it per what this amendment would do, that if, let's say, new new information came forward with regard to the lack of supply on vaccines on, let's say, mental health in healthcare workers, that it wouldn't be fulsome. There might be other witnesses that want to submit written briefs. So, you know, I'm wondering if, like, somebody could, like, perhaps chair, you know, in after our fourth set of topics, that we could have a business meeting at that point in time to look at what comes up next and review evidence. I think that's kind of standard operating procedure. But at this point in time, I mean, after this, we dispense with this motion. I actually want to talk about a couple of procedural things. Because I don't like, we're having amazing witnesses at these committees and we're barely being able to scratch the surface of their testimony because we're taking up 6 minutes of housekeeping on the front end of the meeting. So to me, I'd rather let the analysts do their job. If there is a moment when we need to issue an interim report, the committee can do that. At this point in time, I would rather keep the process open for Canadians to submit written briefs that the analysts and committee members can use in their deliberations, and that we go through one set of topic selections. So because of that, I will be voting against this amendment, and with the hope that more Canadians can participate in the process. Thank you.
Thank you, Ms. Rempel-Garner. I should note again that there's no suggestion of issuing such a report on these bases, and it doesn't preclude the briefs. And in fact, implies that briefs received, certainly to date, are going to be considered. Mr. Davies, please go ahead.
Thank you, Mr. Chair. Well, I have something to say, but I'm also a little confused by this. The second time you've referred to not issuing a report. I'm not sure I understand what you mean by that, because I thought the whole purpose of the motion is to have the analysts prepare a report. Obviously, we'd have to go through it. I mean, that's what an interim report is. So maybe if you can come back to me, Mr. Chair, for my comments on the main thing, maybe could you clarify what you mean when you say there's no suggestion that we would be issuing an interim report?
Yes, that's my understanding of Mr. Van Bynen's motion, is that we asked the analyst to prepare a report. That report could be made available to us as a committee, but it doesn't go further on to say that we should consider this, you know, that we actually issue that to Parliament on any particular time schedule. It's really up to us as a committee to decide whether or not to issue that report, or whether to consolidate them with other reports as we accrue them over time. Certainly, if we wish at some point to issue the report to Parliament, we would have to take some time to go through the report, make sure the recommendations were appropriate from our respective points of view, and so forth. But Mr. Van Bynen's motion is simply only to ask the analysts to prepare such a report. That's just how I understand what we're dealing with, and I hope that that adds clarity. Go ahead, Mr. Davies, if you wish to resume.
Thank you, Mr. Chair. Well, it could be just me, but that's not at all how I understood it. And even judging by Mr. Van Bynen's and other comments of members, I think most members are understanding that the purpose of this would be to have a report prepared for us. We'd go over it, and of course we would issue it. It wouldn't be of any assistance to anybody for us to produce a report on mental health for our own purposes. I mean, I would think the value of it would be in, once we come to an agreement, issuing that report, both for the public and for the government. But you may be correct that it just wasn't mentioned in Mr. Van Bynen's motion. But in my mind, I'm thinking of the whole purpose of an interim report would be to produce something productive that we could then issue as a committee. I like Mike's suggestion. I think that's a reasonable one. And I wanted to make sure I understand it, that if his motion seemed to me that we would have the analysts prepare an interim report on each of the 4 priorities, but not release them until the end of the 4 priorities meetings, and then we could discuss as a committee all of them at the same time. Okay, I see that thumbs up. And then I would think we would issue an interim report on the 4 priorities at that point. Once again, I think that's not exactly what I was talking about before, but I think it's a good idea. And it, as long as if we do that, we haven't lost sight of the fact that we have this mountain of interim evidence that we've received by many witnesses who took time out to come to our committee from February until really the end of 2020. That I still think we have to get that evidence summarized, and perhaps that's a larger project to do after we do this. But I think that that Mike's suggestion is a good one, and it's fair to all the parties, and it'll be released at the same time. And I think it pays respect to Tony's idea on mental health, but also respects the other parties' priorities as well.
Thank you, Mr. Davies. Mr. Van Bynen, please go ahead.
Thank you. I agree with what what Donna said, and the intent would be that each one of these segments, as we've identified them, would be a chapter in the overall study. And so I think the recommendation and the amendment that Mike is proposing is a good one, because it allows us to consider each one of these chapters and the effect of the overall study more effectively. So I appreciate that amendment, and I would be supporting it.
Thank you, Mr. Van Bynen. Ms. Rempel-Garner, please go ahead.
I'm not sure anyone's clear on what's being proposed here. This is how I would like to proceed. The analysts do their job, as they've been admirably doing. They're reviewing the material that's coming in. They're preparing a draft report. And since this amendment doesn't really have any date in which we would be reviewing that, we're kind of just proceeding normally anyways. I'm not comfortable with wording on an amendment that could potentially be used to weasel out of one of our conservative selected meetings on vaccines. And the amendment has now been amended so many times that I think that the Liberals should have gotten their ducks together and actually formally crafted this, and maybe just picked up the phone and given myself a call or any one of our colleagues ahead of time. So I would like to move to adjourn debate.
Thank you, Ms. Rempel-Garner. The motion is to adjourn debate. I'll ask and there is no debate on this. I'll ask the clerk to conduct a vote on that.
Mr. Fisher?
No.
Mr. Kellaway?
No.
Mr. Pawlowski?
No.
Ms. Sidhu?
No.
Mr. Van Bynen?
No.
Mr. Barlow?
Yes.
Mr. D'Entremont?
Yes.
Mr. McGuire?
Yes.
Ms. Rempel-Garner?
Yes.
Monsieur Thériault?
No. No.
Mr. Davies?
No.
So yeas pour 4, nays contre 6.
Thank you. The motion to adjourn the debate is defeated. We go now to Monsieur Thériault. Monsieur Thériault, allez-y, s'il vous plaît.
Oui, merci.
Thank you, Mr. Chair. I would like to indicate that by definition, an interim report is interim. And the question of vaccines will probably go up until the moment where we table the final report, as long as we don't have herd immunity. We haven't determined, the committee hasn't determined that there would be only 4 meetings. It is possible, given the situation, that at a certain point we can add as a group in solidarity, and the committee can set its own schedule. But we know for a fact that at the time there will not be any work on this report as long as we haven't gone through first a round of all the priorities, each party's priorities. And that's why I think that at this point, my colleague's argument doesn't stand. And if the situation did involve an additional meeting more than 5, 6, 7, 8, there's nothing preventing us from doing that as long as we can have a document where we can see at what point we are. That's essential from a methodology point of view. That's why I agree with the motion, and I will stop here.
Yeah. I should remind the committee that we are operating under the terms of Mr. Davies' motion of, I think it's the 13th or so of November, which is that if we wish to do more than 4 meetings on a given topic, we require unanimous consent to do so. That having been said, I see no more hands raised. Mr. Fisher, are you?
Yeah, I have my hand up, Mr. Chair. I hear Luke, and it makes sense. I hear Don, and it makes sense, and I hear Mike, and it makes sense. I think we're going to get to a place where I hope the whole committee wants to get. Nobody wants to weasel out of anything. Everybody wants to get this work done. So I'm not sure. I guess next step would be to finish out debate and then move to the vote on the amendment. But I get the sense that what Mike is proposing and what Don is saying and what Luke is saying are all in that same ballpark, and I certainly hope that's the case because I think that's a reasonable way forward.
Thank you, Mr. Fisher. Mr. Davies, go ahead.
Well, just I think it's really important that we all are really clear on what we're saying, and Michelle's comments left me with some concern that maybe we're not. To make sure that I've got it right, what we're talking about is hearing all the meetings on the first priority. So we've already done 4 on mental health. We're going to do 4 on vaccine. Then we have the blocks priority. We have not determined how many meetings, whatever that'll be, up to and including 4. And then we have the NDP priority up to and including 4 on whatever our priority is. What the motion is to do is to instruct the analysts to, throughout the process, to prepare an interim report on each one of those topics. And at the end of all of those meetings, that's when we will schedule our meetings to go over the reports all in one shot, and we'll issue hopefully one interim report on all 4 priorities. The reason I want to clarify that is because Michelle tended to be concerned that we would be taking up meeting time of our priorities, but that's not how I understand it, given the order, and I see a lot of head nodding, so I think what I expressed is what we are kind of getting at. Yeah, and if that's the case, taking a meeting or 2 at the end of the first round of priorities to assess the interim report, and it usually takes a couple meetings to go through a report. I don't think we need to take more than 2 meetings to do that and issue that interim report before we then start the round of second priorities of parties. I think makes sense. And if I understand it properly, then I'm in favor of what I just said. If that's what Mike and Tony are okay with.
That's my understanding as well. We'll go now to Ms. Rempel-Garner, please.
Oh, thank you, Chair. Just given the fact that it'd be kind of tough for me to trust the government because sometimes they say some things and then do a different thing. I was wondering if Mr. Kellaway could read the motion exactly how it would be as amended, just to make sure that what is being said is actually what is being prescribed in the motion.
Okay. Just a point of clarification, you're not being asked to trust the government, you're being asked to respect the members of the committee before you.
Point of order, Mr. Chair. Actually, Mr. Fisher does have a government appointment and has been part of debate and is part of committee. So I'm assuming that as the quarterback of the Liberal side, he's speaking on behalf of the government.
Be that as it may. So we have Dr. Pawlowski next, and following that, Mr. Kellaway, if you wish to restate your amendment, I'll invite you to do so. Dr. Pawlowski, please.
Just in response to Don's point, I think if we took a meeting or 2 after completing everybody's round of of their topic. I think this is a good idea to summarize things, but it would also be an opportunity to, at that point, decide that some of these issues we may need to revisit. This is going to be a couple months down the line. Maybe the situation with respect to vaccines has changed and we want to bring back, have more discussions on vaccines, but I think that would be a good opportunity to kind of figure out where we are and where we ought to be going.
Thank you, Doctor.
Could I just have a point of order, Mr. Chair? It's really more of a point of clarification, just because
yes,
I don't want us to get off. I didn't mean to suggest that we have a meeting after each priority. It's the meeting that we discuss report would be after all 4 priority meetings are heard. Is that, I see Marcus like, okay, thank you.
Yes, okay. All right, so I'm going to ask Mr. Kellaway to restate his motion, but I'm also going to encourage us all to wrap this up quickly because we're going to get booted from this room very quickly for the next group. So, Mr. Kellaway, if you please.
Sure. Thanks, Mr. Chair. Instruct the analysts to prepare an interim report for each of the topics of study as we conclude their meetings, and from them to be reviewed at the end of the first round of topics.
All right. Is everyone clear now? Are we ready to vote on Mr. Kellaway's amendment? Seeing no hands raised, I shall ask the clerk to conduct the vote.
Mr. Fisher?
Yes.
Mr. Kellaway?
Yes.
Mr. Pawlowski?
Yes.
Ms. Sidhu?
Yes.
Mr. Van Bynen?
Yes.
Mr. Barlow?
No.
Mr. D'Entremont?
Nope.
Mr. McGuire?
No.
Ms. Rempel Garner?
No.
Monsieur Thériault?
Oui.
Mr. Davies?
Yes.
So 7 yeas, 4 nays.
Thank you, Mr. Clerk. So Mr. Kellaway's motion carries. We go back to the main motion as amended, and if there's any discussion. Seeing none, I shall ask the clerk to conduct a vote on the motion as amended by Mr. Kellaway.
Mr. Fisher?
Yes.
Mr. Kellaway?
Yes.
Mr. Pawlowski?
Yes.
Ms. Sidhu?
Yes.
Mr. Van Bynen?
Yes.
Mr. Barlow?
Oppose.
Mr. D'Entremont?
No.
Mr. McGuire?
No.
Ms. Rempel Garner?
No.
Monsieur Thériault?
Oui. Can't go to him.
Pardon, j'ai pas. Pouvez-vous répéter, Monsieur Thériault?
Oui.
Mr. Davies?
Oui.
So 7 yeas, 7 pour, 4 nays, 4 contre.
Thank you, Mr. Clerk. Ms. Rempel, I understand you wanted to take up some procedural matters. We are really running out of time. I know that you're concerned about the time we spend during the preamble of each meeting. I should advise that the clerk has given me indication that he's going to tailor those scripts a little bit, depending on whether we have members in the House or not. Is this something that you need absolutely to raise now, or
I do, because
okay.
Chair, I think that the average amount of time that you're taking to read housekeeping items at the front of each meeting, which are repetitive, actually takes a full question round away from members. So I think that needs to probably be changed so that it's more efficient. I think most of what you're reading is known operating procedure and could be emailed to members and also advised to witnesses prior to the start of committee meetings. The other thing I would say is, I've said this many times, witnesses should be sound tested, especially when we're doing 2 tight panels. Before the start, when a meeting has really already started. So with that, I move that in an effort to maximize witness testimony and MP questioning time, the clerk and the committee communicate to all witnesses and members all protocol, procedure, and technical information prior to a meeting to ensure that this information does not need to be repeated during a meeting.
Thank you, Ms. Rempel-Garner. Is there any discussion on this amendment? Or sorry, on this motion? Seeing no discussion, I shall ask the.
There's people with hands up.
No, Mr. Chair, I had my hand up, and I see Mr. Davies had his hand up as well.
Sorry, I apologize. That part of the screen was masked off, so I'm sorry. Mr. Davies, please go ahead.
Thank you, Mr. Chair. Well, I support what Ms. Rempel's saying, and I also want to raise the repeated issue that Mr. Theriault is struggling with. I think witnesses have to be instructed that they have to have a headset, because that seems to be the problem. Is if they don't have the headset, then the interpreters can't get it. And I think Mr. Theriault, I think he's holding back. Actually, I think there's more interpretation issues, and he's graciously trying to not interrupt the meetings. But it's completely unfair that he has to be put in a position of interrupting. And so I don't think any witness should be allowed to testify unless they have the proper headsets or arrange them. Or in the case of Dr. Bogach, I think he had an acceptable, it looked like he had a pretty skookum microphone there, but the interpretation issues have to be ironed out before the meeting starts. I understand there could be a glitch here and there, but it shouldn't be an equipment-based one, because equipment can be worked out in advance. The other thing I want to just serve notice on, just to get my colleagues thinking about, I will probably move a motion on this coming up, is we have these superb witnesses coming. Like, we just had two powerhouse panels of some of the best witnesses maybe in the world, and we could barely scratch the surface. I mean, giving them 5 or 6 minutes to talk and then 6 minutes of questions is not enough. I know that we're constrained by the motion from the House in some respects, but I would like to sort of have us all think about how we can maybe change this. It'd be nice to have maybe 4 witnesses for the 2 hours, so that we can give them a full 10 minutes, and then we have second rounds of questions. And also, I know that some members of this committee are not even able to ask questions because we only get the first round. Again, I know that we're dealing with the House motion, but maybe this committee can change that, or we can go back to our whips and maybe amend that motion somehow, because hearing 8 witnesses in this time period, in this format, does not do justice to them nor to us. And then I just wanted to throw that out so that I'd be interested in my colleagues' thoughts on this at a future meeting.
Thank you. I should point out that the clerk does extraordinary effort to get people headsets and so forth, and to go through technical stuff. That's why he needs several days' notice. Our Minister of Health from Saskatchewan, for example, we only knew that he was going to be able to make the meeting 10 minutes before the meeting started. There's no opportunity to get him the headset and make sure that was available. So I would certainly encourage everyone, to get their witnesses together on any given meeting very soon, so that the clerk has ample time to locate them, to continue to communicate with them, and make sure that they have the technical, the headsets and so forth. The House of Commons is, ready, willing, and able to send out headsets to everybody, but they just need time to do that. I think we're running out of time here. Do we have Mr. Van Bynen? You have a
Mr. Chair. Thank you, Mr. Chair. I fully the point that you've raised is a point that I wanted to raise as well. Is that we need to make sure that all of this equipment is in everybody's hands, and so we need adequate notice. But I think that this may require some further discussion, further consideration. So I would move that we adjourn the debate to the next meeting.
So once again, we have an adjournment to a date certain. So this would be an adjournment until after the minister's meeting on Friday. Mm-hmm. So there is no debate on this. I will ask the clerk to conduct the vote on this.
Mr. Fisher?
Yes.
Mr. Kellaway?
Yes.
Mr. Podolsky?
Yes.
Ms. Tidou?
Yes.
Mr. Van Bynen?
Yes.
Mr. Barlow?
No.
Mr. D'Entremont?
No.
Mr. McGuire?
No.
Ms. Rempel-Garner?
No.
Monsieur Theriault?
Oui.
Mr. Davies? Mr. Davies?
Yes.
So 7 yeas pour 7, nays contre 4.
Thank you, Mr. Clerk. So this debate is adjourned until following the minister's appearances in the next on Friday. So that concludes our business. Thank you all. Good meeting, interesting discussions, and we'll see you on Friday. So thanks, everybody.
See you in Q.